Morning everyone, myself Dr. Fatima Noble. I'll be presenting on visual and anatomical outcomes in IOFB removal. Coming to the case scenario, a 35-year-old male with history of injury to the right eye while working, diagnosed with full thickness corneal tear on anterior segment with indirect ophthalmoscopy suggestive of intraocular foreign body, which was later confirmed with CT scan. Patient and relative were anxious about visual prognosis, so it is necessary to find out the factors responsible for the same. So going through some literature, I decided to do detailed study on prognostic factor in the case of IOFB removal. My study included 46 cases of posterior segment IOFB, which were reviewed retrospectively from 2014 to 2019. Demographic data included age, sex, entry site, and time interval between injury and repair. There was 7% female and 93% male, with mean age coming to 33 years and mean follow-up coming to 9.4 days. I included all the patients with history of trauma with IOFB and excluded previous ocular surgery except cataract surgery and previous ocular pathology affecting vision and of course not willing for consent. They all were assessed by slit lamp examination, fundoscopy, B-scan ultrasonography and CT scan. Out of 46 patients, 7 underwent 23 gauge vitrectomy with IOFB removal, 15 patients underwent 23 gauge vitrectomy with IOFB removal with lensectomy, and 23 patients underwent 23 gauge vitrectomy with IOFB removal with lensectomy and IOL implantation, with maximum of 26 patients had silicone oil as an internal tamponade. Coming to the association, intraocular foreign body was associated with corneal tear, cataract, endophthalmitis, retinal detachment, and vitreous hemorrhage. Found out that 61% patients had poor visual acuity with corneal entry wound, while scleral entry wound had a good visual prognosis. Coming to the site of the lodgement, it was found out that 61% patient with foreign body lodged in the vitreous cavity had better visual outcome than 15% patient having IOFB lodged at retina. Constituted majority of intraocular foreign body had a good visual outcome than a non-metallic foreign body, while intraocular foreign body with less than 4 mm in size had a better visual outcome with intraocular foreign body with more than 4 mm in size. According to my study, it was found that 100% cases were associated with endophthalmitis, 53.3% cases with cataract, and 69.2% patient with corneal. Time interval between trauma and surgical intervention is a controversy. Earlier, it was thought that removing large intraocular foreign body can prevent endophthalmitis, but recent studies suggest that late surgery can improve outcome in cases of metallic foreign body where inflammation is reduced and intraocular foreign body can be handled well. Found out that overall log mark of best corrected visual acuity improved significantly after IOFB removal. In our study, it was found out that young males, industrial workers, are at the greater risk, and the outcome depends upon the size of the IOFB, which increases the frequency of uveal prolapse, cataract, and hemorrhage, the site of the lodgement, the entry wound, endophthalmitis, and the type of intraocular foreign body, with non-metallic being the worst outcome. So, our prognostic factors are useful in evaluating the severity of trauma and determine the appropriate therapy and predict prognosis. Thank you.